Welcome to the older adult physical activity and exercise. It's important to note that as we age, we get drier and stiffer, and so a lot of the age related changes occur as a result of drying and stiffening of the tissues of our body. I have several handouts for this chapter for you guys that you will get in class to help complete your activities in class, but it's about deciding and determining how age affects our ability to exercise and our participation in therapy. So definitions and descriptions applied to older adults. I know I've told all of you guys that you need to reframe your perception of old, and this chapter aims to do that with some specific guidelines. Factors that contribute to successful aging include the absence of disease or disability, high cognitive and physical abilities, and meaningful social interaction. And if we look at this, we can again see there is a biopsychosocial approach to qualifying something as successful aging. We've got both quantitative and qualitative definitions of old or of age. And so young old we define as 65 to 74 years of age, and they may or may not be retired. They typically care for family and participate in recreation. Then our mid old population is going to be 75 to 84. They are experiencing more age related changes and may work towards simplifying their life, and many may rest during the day. And then we get to our old over the age of 85, and they typically have a significant decline in physical function and may reflect on the meaning of their lives. Historically, the young old were what we considered as old in sociological evolution. And now, as we have increased our lifespan and our participation in community beyond the age of 65, we've incorporated these different levels. So you can go ahead and pause to read each of these descriptions of young old, mid old, and old, but they are just quick patient profiles to give you a little idea about what a patient from each age range might look like. So when we look at aging, we have both primary and secondary aging. And primary aging is the passage of time, and it's just a result of what happens with the clock ticking away. Secondary aging is the result of disease and disability and can also be contributed from the environment. But there is a decrease in physiological effectiveness that happens with aging as a result of primary aging. Secondary aging is what happens that kind of expedites those processes. And so when we look at the effects of senescence on body systems, we have cellular and organ changes, and we can see changes that include hypertrophy, atrophy, hyperplasia, and neoplasia. Our brain and our muscles most commonly atrophy with aging, while our heart and our kidneys hypertrophy with aging. And integumentary changes include decreased elasticity, decrease in turgor, increased dryness, and decreased sweat gland activity. So again, remembering we get drier and stiffer. Organ reserve changes that the body experiences begin at age 30. We have a degradation of 13 organ systems and 24 variables such as VO2 max. And where we see the greatest impact in the heart, lungs, and kidneys. The musculoskeletal system begins to have a 1 to 2% decline per year after the age of 25. And we experience sensory loss or sensory changes, including loss of vision, loss of hearing, and loss of touch. All of these changes contribute to the deficits in function that occur as a person ages. So health decreases with aging, and we can look at statistics to prove that, such as arthritis affects more than 80% of the population over the age of 55. Walking and climbing stairs are the most commonly reported disabilities. With age tends to come decreased activity, with sedentary behavior contributing, and that tends to cause an increase in physical decline. Sedentary behavior creates a decrease in muscle mass, bone mineral density, and impairment in other body systems within the first week of bed rest. And we see 10 to 15% of strength lost with every week of bed rest thereafter. So whether it's an effect of just a lifestyle change that has reduced activity, or a secondary aging impairment such as disease or disability related to heart failure, pulmonary disease, whatever the case may be, any prolonged periods of bed rest tend to be detrimental to a patient's ability to recover because of the decline that they experience within muscle mass, bone mineral density, and neuromuscular firing. They'll also experience hypokinesis, which is slowed movement, immobility, and functional limitations, including decreased strength and endurance and increased balance deficits that result in decreased independence. And we will see common gait deviations associated with aging that include decreased hip extension because of that forward flex posture, a wider step width to try to increase the base of support due to a decreased stability and balance deficits, a decreased stride length, and a decreased gait speed. So if we look at age-related changes in immobility, we can see after the age of 40, we get a 0.5% loss per year in muscle mass, 1 to 2% loss per year. After the age of 50, 3% loss per year after the age of 60, and the rate is increased with sedentary behaviors. Changes related to immobility, we get atrophy after 72 hours, 14% atrophy of type 1 fibers, and 17% atrophy of type 2 fibers. So obviously seeing an impact to our ability not only to generate power in that initial, but also maintain power with the endurance factor. Whereas a 50% decrease in strength related to age, and bed rest causes, again, that 10 to 15% of loss per week. Our leg muscles, anti-gravity, weaken faster, and after 5 weeks of complete horizontal bed rest, there's a 26% decrease in strength of the plantar flexors. Power loss begins at age 30, and there's a 75% decrease in power through the aging process. With bed rest, there's a 33% reduction in power with inactivity in an older population compared to a younger population. And so that again shows us why activity is so important in our older adults. Muscle mass, we see a reduction in muscle fibers and cross-sectional area. And flexibility, there's a decrease in range of motion at all of the major joints, 6 degrees per decade. And again, we see effects of both of those things with the implementation of immobility or bed rest as well. Looking at oxygen consumption with aging, we see declines are seen in the effectiveness of each component of oxygen consumption. So, we get an overall decreased cardiac output, overall decreased VO2 max, overall decreased stroke volume, and so all of those things end up contributing to decreased oxygen consumption. The ACSM says don't prescribe underdosed strength training programs for older adults. Instead, match the frequency, intensity, and duration of exercise to the individual's abilities and goals. And basically this is saying that we have to be careful when we're working with the older population that we don't overtax them, but it is also easy to use your age bias and assume that they are old and cannot do enough and that you under prescribe your exercises. And so make sure that you are unique to your patient's needs, you individualize your prescription, and you make it appropriate for their age and functional ability level. Improved strength in older adults is associated with improved health, quality of life, and functional capacity, and with a reduced risk of falls. Older adults are often prescribed low-dose exercise and physical activity that are physiologically inadequate to increase gains in muscle strength. Failure to establish accurate baseline levels of strength limits the adequacy of the strength training dosage and progression, and thus limits the benefits of the training. A carefully developed and individualized strength training program may have significant health benefits for older adults. Considerations prior to implementation of exercise, we want to look at the patient's risk factors, and so we'll look at fall risk assessments, whether those are the functional assessments that we've talked about in class or other measures such as the STEDI, which I will give you guys a handout of. We also want to look at fracture risk assessment. Obviously, bone mineral density decreases with age, and so they are at greater risk for fracture, and we don't want to apply resistance exercises to somebody who is a high fracture risk and have a fracture occur in the clinic. We also want to consider that most older adults are on multiple medications and what the effects of those medications are. And you guys will have a handout in class of the different classes of medications, the effects of those medications, and the implications for therapy. It's important to familiarize yourself with those and create some mnemonics to identify them so that you can adjust your treatment appropriately. We will talk about a few more specific medications as we go into each of our diagnoses this semester, but it's important to just remember that most adults are on multiple medications, and we consider polypharmacy to be 4 or more medications, and most adults are under some amount of polypharmacy. In older adults, it is critical to pay special attention to their social history, support system, living environment, and current and recent levels of function related to basic and instrumental ADLs. We have a vulnerable population within older adults, and so especially if they are under the care of somebody else, it is important for us to pay attention to what that care is like, what all the contributing factors are, who is caring for them, and what support systems are in place and what may be contributing to any decline that the patient experiences, and report abuse or neglect as appropriate. Barriers to learning, from cognitive status to sensory losses, must be considered, as well as screening for abuse and self-neglect. Key interview questions for the older population for related functional mobility may include: how much difficulty in your daily routine do you think you have in getting up and down from the floor? Trying to identify osteoporosis. Example might be: have you gotten any shorter? Any height loss? How tall were you at the age of 25? Dietary questions may include any loss of appetite, any difficulty chewing, any use of dentures, how much water do you drink every day? Aspiration might be identified through questions such as: do you have any difficulty with swallowing? Do you cough after eating or drinking? Incontinence can be addressed by asking: do you have any involuntary loss of bowel or bladder? Weight can be addressed with: have you had any recent weight loss or gain? If yes, how much? We can identify issues related to fatigue by asking patients questions such as: are you tired? Do you feel refreshed after sleeping? Do you have periods of the day where you have more energy than other periods? Dizziness can be identified by asking a straightforward question such as: do you have episodes of dizziness? Confusion we can address with: do you ever have difficulty remembering things? We can also ask those orienting questions such as: do they know where they are? Do they know what the date is? Do they know any major popular event that's happening related to date or time? And then enjoyment, which anhedonia is related to depression or dementia, and so anhedonia would be the lack of enjoyment. We want to identify any patients at risk of anhedonia through questions such as: are there things that you no longer enjoy? Or seeing what their social interactions are like. Elder abuse. So there's a couple different types of elder abuse that we're going to talk about, and it's important to be aware of within the older population so that you can make your reports as necessary. In the state of Oklahoma, as a healthcare provider, you are a state mandated reporter for vulnerable populations, and this includes children and elderly and disabled. And so our types of elder abuse are going to include physical abuse, which the use of physical force against an older adult that may result in bodily injury, physical pain, or impairment. Sexual abuse is going to be any non-consensual sexual act with any kind with an older adult. Psychological abuse is infliction of anguish, pain, or distress of an older adult through verbal or nonverbal acts. Financial exploitation is illegal or improper use of older adults' funds, property, or assets. And neglect is the refusal or failure to fulfill any part of a person's obligation or duties to an older adult. So it's important to know, again, that in the state of Oklahoma, you are a mandated reporter where there is a reasonable suspicion of abuse. And so when you have a suspicion of abuse in a non-emergency abuse situation, your action is to inform the supervising PT so that you can both monitor for reasonable suspicion. If you have an emergency related suspicion of abuse, you would immediately inform the Department of Human Services in the state of Oklahoma. Again, there's no retaliation for reporting a reasonable suspicion. It's just a matter of having them look into it, but there are repercussions if you fail to report it. Important things to consider prior to implementing exercise in the older population are taking a look at the objective measures to assess their strength, power, fall risk, and functional ability. So again, looking at the handout that you will get in class, there are a couple of objective measures that we can look at for power. Gait, falls, balance, and endurance are going to all pertain to the functional assessments that we've talked about in the previous lecture and that we have looked at in class. Grip strength, we've played with a handheld dynamometer, but you're welcome to take a look at it in class again as far as one of those assessment options. Either way, with our objective measures or our strength measures, rather, we need to be precautionary when we're doing manual muscle testing because not all patients as they age are appropriate for isometrics with the risk of Valsalva. And so, depending on cardiac comorbidities or pulmonary comorbidities, whatever the case may be, we want to be precautionary in the older adult population on whether or not traditional manual muscle testing is appropriate. Exercise in the older adult should be a multi-dimensional program. It should include aerobic, flexibility, resistance, and balance activities, as well as patient education regarding lifestyle modification to help the patient recognize what can be done in their daily routines and that would decrease energy expenditure and promote an increased activity level overall. Aerobic exercise for the older adult is recommended at 150 minutes per week of moderate intensity exercise. And remember that 10 minutes per bout is the minimum amount of time that we want to contribute to an exercise in order to have it count towards that 150. Flexibility is recommended to do stretching at least 10 minutes twice per week, and it is critical to use any newly gained range of motion to maintain it. So remember, whatever we stretch, we want to make sure that we strengthen within that new range and we promote those things. But we get drier and stiffer as we age, and so flexibility becomes more important to incorporate stretching on a more regular basis. And balance and training needs to have emphasis on the functional demands for that individual patient. When providing the older adult with instructions for balance exercises, it is important to consider that they have good sitting balance before we take them to any standing activities. Do they have trunk control in a seated position without upper extremity support before we try to superimpose lower extremity control on that? So make sure they have good sitting balance before we proceed to standing activities. We want to make sure that we have safety measures in place, like using a secure surface where the individual can grab with one or two hands, like the parallel bars when necessary, standing in a corner or in front of a stable sink or chair or desk when we don't have equipment such as parallel bars, always utilizing a gait belt when needed. Those things are very important in the older population with a higher fall risk. We want to make sure that we challenge the person at the level where they are safe, but also where they are receiving a challenge. So we can consider modifying things such as their base support, their support surface, superimposed movements, perturbations, and their surroundings, making sure that we are adequately challenging their balance systems while not overloading them to the point that they become a fall risk by performing the activity. As we improve strength and balance, we want to make sure that we progress the functional activities and progress the interventions that underline or that address the underlying balance problem. Dynamic activities need to consider the limits of stability with their reaching, leaning, and ensuring modifications even to base of support as far as maintaining a staggered stance or taking a step instead of reaching, depending on what the patient's safety levels are. Anticipatory postural control needs to be addressed in the older population. For example, when we perform sit-to-stands, we have a tendency to anterior weight shift forward to get to a standing position, but then as we stand up, we have the compensatory rock backwards. And so that postural control needs to be available for the maximum safety for our patient. So we can have them perform sit-to-stands, we can have them do alternate stair touching, we can have a single leg stance, but anything that's going to require positional change with the body needing to anticipate that change and maintain an erect position. We can also look at reactive postural control, such as in place responses, moving forward, backward, taking compensatory steps to maintain that balance, but how do they react to a balance disturbance? Sensory orientation is going to include putting them on unstable surfaces or inclined surfaces or taking away their visual cues And again, I have some level of debate on what applies most to function when we take away visual cues, but it does force us to rely on our other balance systems, and so it is a valid intervention technique. We also want to work on stability in gait, such as gait on level surfaces, at variable speeds on unlevel surfaces, incorporating head turns, adding in horizontal and vertical head turns, adding in pivots to our ambulation, going over obstacles, going up obstacles, and then overall progressing all of that function together when the patient is ready. So examples for functional activities that you can perform with the older adults would include sit to stand using the hands on armrests that you can progress to one hand or the use of no hands, rising up on their toes and then progressing to toe walking, rocking back on heels and progressing to heel walking, side walking or backwards walking, reaching for objects and picking up overhead, behind, to each side, toward the floor, progressing to transitional movements in positions such as floor transfers or stair climbing, incorporating dual task activities that incorporate cognitive and physical demands such as carrying laundry, counting cereal sevens, naming breakfast items, and integrating functional activities that the patient enjoys such as golf or tennis, or pickleball in this day. Resistance exercises, we want to consider some special safety things, including the comorbidities that may be present. As a patient ages, the more likely they are to have multiple comorbidities associated with their diagnosis or just their age in general. And so what influence do those comorbidities have on our exercise prescription and whether or not they can do resistance exercises? Remember, our cardiac patients, we're not likely to want to have them perform a Valsalva maneuver, and so we're not going to have a whole lot of isometrics in our resistance program for them. Home modification recommendations to increase safety are often the PTA's responsibility, and so educating a patient on things like picking up throw rugs to remove fall risk items, installing night lights to increase visual acuity throughout ambulation when they have to go up to the bathroom in the middle of the night, or clearing out hallways of furniture that limit the amount of accessible space to ambulate. All of those things are accommodations that can often fall, or recommendations rather, that can often fall to the PTA to educate the patient on, because we spend the most amount of time with our patients than any other healthcare providers, and so we get to hear the most of what they're struggling with. Also, home health therapy, going into the home, you've got the most direct access to make those changes. And so it's important to educate your patient on just those small things to maximize safety. We also want to look at determining the safe positions and appropriate equipment that match our patient's need, current status, and capability, remembering that some patients with a super kyphotic posture because of the way that they have stood their entire life, and that's just their old lady status, isn't probably going to be able to get their back up against the wall for whatever scapular retraction exercise on the wall you may want them to do. And so how do we modify that? How do we make sure that we can get them in the most comfortable, most appropriate position based on age-related changes? And then just make sure that you're modifying to meet the patient's needs and safety requirements, no matter what exercise or equipment that you choose. The intensity of the exercise, if your patient can complete 8 reps but not 15 reps with appropriate form, then you're probably working at an appropriate intensity level for the geriatric population. We want to be able to clearly and appropriately get through 8 repetitions of an exercise without any issue, but fatigue before being able to do more than 15 of them, because that's going to demonstrate that the patient is at the appropriate intensity level. If they can do more than 15, then it's probably not hard enough and we need to add more resistance. We recommend that patients use active recovery. So while resting one muscle group, we work another muscle group. So that way the patient's heart rate is still staying appropriately elevated for exercise. We're not dealing with as many fluctuations there, but we're also maximizing oxygen consumption and overall functional endurance. When we're looking at frequency of exercise, we want to consider what the patient's tolerance level may be and when they experience periods of low energy, and educate them on the best frequency based on their functional demands. Speed of exercise should always advocate on the side of safety and not speed, and progression should be done at a rate that, again, challenges the patient sufficiently so that we are pushing them beyond what they are currently capable of, but does not overly tax them to the point that we fatigue and are not able to maximize what we can do in an entire session. Functional training for the older adult should always be geared towards increasing independence. Falls in the older adult are common, and so we have our various fall risk assessments. We also have the STEADY, which is a handout that I will give to you guys. I think I mentioned that earlier. That is a pretty commonly applied one through other medical professionals, and so you might see nursing apply it in an acute care setting where they give you a STEADY score, or it's something that their primary care provider is done and is sending over in the documentation. And so it's not an assessment that we in therapy will regularly perform, but you will often see documentation from other providers about it, and so it's important to at least know what it's referencing. We'll also look at screening for osteoporosis. Again, that's going to go back to our fracture risk and the importance of exercise to reduce fall risk in the older adult population. All of the research supports exercise as a fall risk intervention, and whether that's resistance training, aerobic exercise, or balance training, there's a benefit from all of them, but the most comprehensive studies say that multi-component interventions that couple aerobic resistance and balance interventions are suggested to reduce fall risk. Common disorders that we want to be familiar with in the older population include dementia or Alzheimer's. 1 in 10 over the age of 65 have Alzheimer's disease is what your textbook says, but I would argue that it's just a form of dementia because Alzheimer's is very specific, and not all fingers are thumbs, but all thumbs are fingers. Not all dementias are Alzheimer's, but all Alzheimer's are dementias. But either way, when we're working with dementia patients, home safety is very important, and that's a matter of familiarity and safety, and it's a balance of keeping both of those things together. We want to make sure that we're pulling up throw rugs in this patient population, especially because they can often be confusing and become trip hazards because of just altered perception. There's often limited compliance with home exercise programs due to memory deficits, and so we need to maximize what we can get out of our sessions and limit how much we're asking them to do in a home exercise program. So basically, when we're giving them an HEP, get the biggest bang for our buck, so that way if they do any of the things, we're hitting multiple areas. These patients may be combative because of confusion. They are often easily irritated, and so you might have an Alzheimer's patient try to swing on you, but that's just something that comes with the territory. And it's also important to be familiar with the effects of sundowning. And sundowning is basically when a patient can seem at a higher cognitive level throughout the day, and then at typically sundown, they have this cognitive decline, they have decreased memory, decreased faculties, all of those things. And it doesn't have to be consistent at sundown, but it just highlights the effect of decreased cognitive function at some point throughout the day. There's a drastic decline. Another common disorder would be Parkinson's. And so considerations that we want to think about for our Parkinson's patients are going to be participation in the LSBT Big and Loud program. So that is where we are looking at utilizing those big over-the-top movements to promote motion, because our Parkinson's patients tend to be relegated to such small little movements, and we want them to be loud and overly vocal with how they participate in these exercises with counting, because again, the vocal cord effects there and the decreased tone or decreased volume in voice that helps combat those things. Other programs for patients with Parkinson's include use of yoga, Tai Chi, Pilates, dance resistance training, cycling, and running as tolerated. Osteoporosis we've hit on a couple of times here, but understanding again the decreased bone mineral density with age is going to increase fracture risk, and so we have to be more careful in the interventions that we select and how we apply resistance so that we decrease risk of fracture in our intervention application. The Other component to helping patients manage osteoporosis is that the bones operate off of Wolff's Law. And so the more that I stress a tissue, the stronger it's going to get. And so appropriate training and stressing of the bone structures can help to combat the effects of osteoporosis. So postural training can be used to reduce the risk of compression fractures, and resistance training and weight-bearing exercises can be used to promote increased bone density. Frailty, sarcopenia, and geriatric syndrome, these are patients who have significant fatigue, high functional limitations associated with decreased activity tolerance. And the exercise demands should not exceed the nutritional intake of the patient because they're essentially have risk of muscle wasting, which can result in rhabdomyolysis and even further bodily harm. And so we have to be very careful in our patients who are frail, have sarcopenia, and geriatric syndrome. Osteoarthritis, we talked about 85%, I think, over the age of 55 have arthritis. And so this is going to be probably our most common disorder. And when we have patients with osteoarthritis, they're going to require increased muscular support to the affected joints to decrease that bone-on-bone contact. And so a lot of our efforts as therapists is going to be around improving neuromuscular firing of the muscles surrounding the joint, improving strength to the muscles surrounding the joint, and decreasing the bony approximation by enhancing muscular activation. And then activity modifications can be taught as needed to help overcome any functional limitations that the patient might be experiencing. Urinary incontinence is another issue that patients may deal with as they age, and this can be caused by weak muscles, dementia, and decreased mobility. There are a couple different types of incontinence, and we will get into those a little bit more when we go into women's health. But for these patients, we're often going to implement a pelvic floor program to help improve neuromuscular firing and strength of the pelvic floor. And then talk about hospice care. So our geriatric population is going to be the most commonly eligible for hospice care, but we as therapists will see people in hospice, and the goals are to increase comfort. So the primary role of the PTA is to provide family and caregiver training. So whether that's teaching them how to transfer, teaching them how to get them in and out of bed, teaching them how to get them around, how to help get them onto a toilet or into the shower, collaborating with OT to do a co-treatment in that training, that is the primary role of the PTA, is training, caregiver training. The emphasis is not placed on the patient's independence, but rather on symptom management and comfort, pain relief, all of those things. So those are the highlights of the older adults and exercise training in the older adults. Please take a listen through again if you feel like you missed anything, and come to class prepared with any questions. And don't forget about the quiz.